Okay, this is a brief video on the genetics of movement disorders. Charcot-Marie-Tooth is a hereditary neuropathy characterized by chronic motor and sensory polyneuropathy. There's distal muscle weakness and atrophy and a high arch to the feet. There's also depressed deep tendon reflexes. Type 1 Charcot-Marie-Tooth, or CMT1, is the most common. This represents about 70 to 80% of patients with Charcot-Marie-Tooth. It occurs in about 1 in 3,300 individuals, and individuals become symptomatic somewhere between the ages of 5 and 25. So there's quite a large range of age of onset. Fewer than 5% of patients, however, become wheelchair dependent. The PMP2 gene is the most common associated with Charcot-Marie-Tooth. And what this gene does is it codes for a protein that covers myelin. The most common change in this gene is a duplication. This is because of unequal crossing over between the two alleles. So you have a duplication of the gene, but it's actually not functioning correctly. Another movement disorder I want to discuss is Huntington's chorea, and this is a progressive motor, cognitive, and psychiatric disorder. And age of onset ranges, but most commonly between ages 35 and 44. It's inherited in autosomal dominant fashion, and it's caused by an expansion of the CAG repeats in the gene. And here's an individual in high school, and here he is in his 40s. This is just actually kind of a detailed slide about triple repeat disorders. And triple repeat disorders are disorders that affect the gene's transcription, or sometimes its protein structure. They can be inherited autosomal dominant, autosomal recessive, or X-linked. Autosomal dominant include Huntington's chorea, and Huntington's chorea, there's an increased number of CAG repeats in the coding exon, and we're going to talk about how that affects it. There's also a number of forms of spinocerebellar ataxia that are also caused by expansion of GAC repeats in the coding exon of the gene. Myotonic dystrophy is caused by an increased number of CTG repeats on the 3' end of the gene, and spinocerebellar ataxia is caused by an increased number of type 10s, SCA type 10, ATTCT, in an intron, so a non-coding region. There also is Friedreich's ataxia is the only triple repeat that's inherited in autosomal recessive fashion, and again, it's a GAA repeat in the intron. And then there's X-linked, most commonly Fragile X syndrome, on the 5' end of the gene. The triple repeats that do not include the exons, they include the 5', 3', and introns. What they do is the increased number of repeats result in the gene not being transcribed, so they're methylated or not transcribed. This is a little bit different than what happens in the case of Huntington's chorea. In Huntington's chorea, the increased number of repeats are within the coding or exon region. And in this case, we have a string of glutamines, GLNs, that are in the middle of the protein. And the problem is this increased number of glutamines affects how the protein folds and how the protein functions. So it affects the actual protein, whereas most of the other triple repeat disorders result in the protein not being transcribed. This, in Huntington's, actually results in abnormal protein. In Huntington's, as is many triple repeat disorders, the number of repeats is associated with the severity, and in the case of Huntington's, the age of onset of the disorder. Normal individuals have about 25 CAG repeats. When an individual has between 27 and 39, while they don't have symptoms, they're at an increased risk of it expanding in the future generation. So it becomes a little bit unstable during reproduction. during primarily the spermatogenesis. Individuals between 40 and 60 CAG repeats usually start showing symptoms anywhere between 35 and 65. With larger repeats, the symptoms become earlier. Between 70 and 90, symptoms can occur in the early 20s, and greater than that, you can even see symptoms during childhood. The larger the number of repeats, the more unstable the region is, and the higher the number in the next generation. And what I mean by that is if somebody has 27 repeats, it may expand to 30 or 35, but once you get to 45 or 60, it might go up by 20. The number of repeats increases primarily during spermatogenesis. This is the opposite of Fragile X, which we'll talk about later, that it expands during oogenesis. So here is a pedigree or family history of a family with Huntington's chorea. And in this individual, 1-1 is normal, 1-2 has 2 alleles, one with 48 repeats and one with the normal 30. Started showing symptoms of Huntington's chorea at age 41. She had 4 sons and 2 daughters, and she passed on her expanded allele to one of her sons and one of her daughters, and yet she had 48. It actually decreased to 47 in her son. She showed symptoms at 41. Her son showed symptoms with 47 repeats at 43. And her daughter showed symptoms somewhere around 40-ish. But her son, as this expands during spermatogenesis, had 3 children. And this child, individual 3-1, had it expanded from 47 repeats to 50 repeats. And he actually showed signs of Huntington's at age 33. The last thing I'd like to discuss is the ethics of testing children for Huntington's chorea. Again, it's autosomal dominant. It is a horrible disease, and often family members want to know if a child would be affected. It is not acceptable to test a child under the age of 18 unless they're showing symptoms. So if they're showing symptoms of a movement disorder or psychiatric issues that are concerning for the presence of HD in the child, then it's reasonable to test them, because you're testing them, you're not pre-symptomatic testing them, you're symptomatically testing them. But it is not reasonable to do pre-symptomatic testing for Huntington's chorea. Sometimes individuals, if they do not want to have an affected child, there's a number of methods that they can use for prenatal diagnosis, pre-implantation diagnosis, but not that anyone would ever be forced to end a pregnancy, but it's usually asked, and they need to be, if they want prenatal diagnosis, they need to accept that they need to end the pregnancy if the child's affected. Otherwise, they're given that child pre-symptomatic information. Again, no one's ever been asked to end a pregnancy. Nobody's ever been forced to end a pregnancy. But the family needs to understand what the consequences are if they do prenatal diagnosis. And that's the end of this module.